Here's a great question on research design in the ED, focusing on statistical analysis in clinical trials. You're leading a journal club reviewing a randomized controlled trial of a new thrombolytic for acute ischemic stroke. The trial enrolled 600 patients and was powered at 80% to detect a 10% absolute reduction in poor 90-day outcomes, defined by a modified Rankin score of 3 to 6. The sample size calculation assumed a two-sided alpha of 0.05. However, the primary analysis reports a one-sided p-value of 0.02, with no justification or pre-specification of a one-sided test. The question, what is the most important statistical concern with this study? Here are the options. A one-sided test is only appropriate if harm is impossible, and this trial should have used a two-sided test because both benefit and harm are plausible. B. Using a one-sided p-value when the sample size was calculated for a two-sided alpha inflates the type 1 error rate and undermines the validity of the reported significance. C. Doubling the reported one-sided p-value to approximate a two-sided p-value shows the result is non-significant, so the trial's primary finding should be discarded. D. Switching to a one-sided test post hoc makes the trial underpowered for its original two-sided hypothesis. E. The clinical importance of a 10% absolute reduction means that statistical nuances about one versus two-sided tests are irrelevant to decision-making. Take a moment to consider your answer. The correct answer is B. Using a one-sided p-value when the sample size was calculated for a two-sided alpha inflates the type 1 error rate and undermines the validity of the reported significance. Here's why. The trial was designed with a two-sided hypothesis, allowing for the possibility of benefit or harm. By reporting a one-sided p-value without pre-specification, the effective false positive rate doubles from 5% to 10%. This mismatch between the planned analysis and the reported results inflates the risk of a type 1 error, meaning the finding may be a false positive. This undermines the credibility of the trial's conclusion. Let's quickly review the other options. A is partly true. Harm must always be considered. But the key issue isn't just the plausibility of harm, it's the unplanned switch from a two-sided to a one-sided test. C is incorrect because simply doubling the p-value doesn't fix the fundamental methodological problem of post hoc testing. D is wrong since a one-sided test actually increases apparent power for a given sample size, but at the cost of a higher false positive risk. It doesn't make the trial underpowered in the usual sense. E misses the point that statistical validity is essential regardless of clinical importance. Even a clinically meaningful effect can be spurious if the analysis is flawed. Key takeaway: always align your hypothesis test, one or two-sided, with your pre-specified sample size calculation and statistical analysis plan. Unplanned use of a one-sided test inflates the type 1 error rate and threatens trial validity. Remember, two-sided tests are the default in clinical trials because both benefit and harm are possible. For further reading, check out the FRCEM learning module on understanding p-values and statistical significance, and St. Emlyn's blog on the importance of statistical significance in clinical trials. That's it for this question. Keep these principles in mind when appraising trial data in the ED. Critical appraisal is massively important for your exam. Nail this and you'll be in a great position for your SBA exam and the article appraisal station in the OSCE.